My name is Susan Vassallo. I'm from the Department of Anesthesia, Critical Care, and Pain Medicine at the Massachusetts General Hospital. I will be sharing with you my thoughts on anesthetic concerns in the hip fracture patient. Disclosures: I have no financial relationships and no conflicts of interest. Let's talk about the hip fracture epidemiology. In the United States, 300,000 to 325,000 people suffer a hip fracture annually. Worldwide, 1.6 million people. Most injuries occur in patients over 65 years. The lifetime risk for women, 14 to 18%, and men, 3 to 6%. Hip fractures, again, more common in women. Here we have a picture up on the upper right of Bill and Hillary Clinton as baby boomers, and then in the later phases of their life. Both of them are at risk for hip fractures, but of course, women more than men. Hip fracture morbidity. The injury itself can have devastating consequences. The significant burdens which may arise are medical, social, psychological, and economic. Medical burdens: cardiovascular complications, pulmonary problems such as pneumonia, renal insufficiency, both acute kidney injury and exacerbation of chronic kidney injury, neurological burdens such as stroke. What about the social burdens from a hip fracture? The ability to return to a prior living environment may be compromised. Mobility may be compromised. Simple walking, driving, and of course, flying. The need for supervision may increase drastically after a person suffers a hip fracture. Independence may be lost or compromised, and the family structure and support system may need to adjust to accommodate a patient who suffers a hip fracture. The economic burdens in the United States in 2010, $17 to $20 billion incurred from total annual hip fractures. It's probably $25 billion in 2020. It is the most expensive diagnosis in the Medicare system. The average cost of a repair of a fracture between hospitalization, surgical repair, as well as physical and occupational therapy, probably $26,000 to $35,000. And then you have to look at the lifetime cost of a hip fracture in each individual patient. Mortality. Mortality in the hip fracture literature is defined as acute, intraoperative, and then 30 days after fracture, and then late, 1 year after fracture. Keep in mind that death is quite rare after orthopedic surgery. So in the United States, the trends. The purpose of my talk today is to share with you the historical and longitudinal trends in terms of morbidity and mortality analysis of patients with hip fracture, and then to share with you some new literature. So acute mortality, that means acute intraoperative or intra-hospital stay for all surgical patients is low, 1%. For hip fractures, it's 3% in the United States. In the United Kingdom, double that, 6%. To give some meaning to this number, patients without hip fractures have a lower mortality. The figure that I remind my residents, my CRNAs, and my colleagues, 1 year later, the mortality from a hip fracture is 20 to 25%. So keep in mind, 1 out of every 4 patients you care for during repair of a hip fracture may die or will die the following year. Mortality. So significant preoperative risk factors can influence mortality. A patient who presents in congestive heart failure, who has unstable angina in the setting of an injury, who suffered his or her MI and then fell, chronic obstructive pulmonary disease, or a patient who has pneumonia, that increases the mortality. Any patient who presents in chronic renal failure with a hip fracture can have advanced mortality. And then a patient greater than 70 years, those are the patients where the mortality increases. The American Academy of Orthopedic Surgeons published Clinical Practice Guidelines, or CPG. They performed a literature review between 2011 and 2014, looking at 1,700 full-text articles, 169 research articles, and 16,000 abstracts. This document is titled Management of Hip Fractures in the Elderly. This is a 521-page document, and they published 25 recommendations. I have reviewed all 25 recommendations, and I'm sharing with you what I feel is most relevant. The strong evidence supports preoperative regional anesthesia for pain management. By that, we mean preoperative nerve blocks such as fascia iliaca, which could be performed in the emergency department or in your holding area. There are similar outcomes for general or spinal anesthesia as reviewed in 2011. The blood transfusion threshold really should be no higher than 8 grams per deciliter unless there's a compelling alternative, such as the patient who does have concurrent coronary artery disease or concurrent carotid artery disease. The moderate evidence supports surgery within 48 hours of admission. That is associated with better outcomes. You may hear from your surgical colleagues, yes, we need to repair this fracture within 24 hours. That may be true, but not at the expense of improving or optimizing concurrent medical morbidities. Use of venous thromboembolism prophylaxis supported by moderate evidence, and postoperative nutritional supplementation reduces morbidity. That's a factor that we often don't consider when we review anesthesia literature. So to remind everyone, the clinical findings, a patient with a hip fracture, the fractured leg is shortened and externally rotated in this image here. Hip fractures. Usually it's a minor fragility fall in the elderly. And again, the leg is shortened and externally rotated. Hip fractures may present with pain in the groin. The x-ray is usually positive. In the physical exam, the patient is unable to straight leg raise. In the young, a hip fracture may occur with repetitive high energy stress fatigue. Again, in the elderly, a minor fragility fall, and there is failure of osteoporotic bone. Don't miss a femoral neck stress fracture. In the elderly, often no initiating activity. Hip fractures can be simple. Remember, the femoral head is an end organ in terms of blood supply. On the left, you see an image of a non-displaced hip fracture repaired with 3 screws through the femoral head. On the right, a displaced hip fracture which required a total hip hemiarthroplasty. So again, types of hip fractures: femoral neck, displaced or non-displaced, an intertrochanteric fracture, subtrochanteric fracture, and the morbidity varies with the type of fracture. On the left, you see an intracapsular femoral neck fracture. On the right, an extracapsular intertrochanteric fracture, the greater trochanter at the highest end and the lesser trochanter at the lower end. Traumatic diseases of the hip. My orthopedic surgical colleague shared this quote with me, which I love. People come into this world under the brim of the pelvis and leave it by the neck of the femur. So types of hip fracture repair: total hip hemiarthroplasty, hip hemiarthroplasty, a femoral device, dynamic hip screw or DHS, the more modern version, a trochanteric femoral nail or TFN. And how does the surgeon decide what is best? The surgeon looks at the fracture, decides what is the best repair, then looks at the patient and says what repair is best for this patient. Is this patient ambulatory or bedridden? And does this patient have concurrent cardiovascular, pulmonary, renal disease? The anesthetic options: regional anesthesia, by that I mean spinal anesthesia, epidural anesthesia, or some combinations such as a CSE. There are peripheral nerve blocks, which we often use as adjuvants to the repair of a hip fracture. Of course, there's general anesthesia. I mentioned local anesthesia. Once every 5 years or so, we will repair a hip fracture in a quite sick patient using just local anesthesia. The hip fracture, the persistent question, does the type of anesthesia, whether it's regional or general, impact acute and long-term morbidity and mortality? Series of retrospective reviews and matched analysis. And then there is the clinical sense of what you and I believe will be best for our patient. I emphasize clinical sense. That's what the patient can tolerate, what the surgeon can perform, and what your skill set is. So again, longitudinal studies. Mark Newman in Anesthesiology 2012 published a review. And in this review, the hypothesis was increasing regional anesthesia has been proposed as a strategy to improve the quality of hip fracture care with a lower 30-day mortality. At that time, regional anesthesia was used as the primary anesthetic in 1/3 of hip fracture surgeries in the United States. This was a retrospective review of over 18,000 patients in 126 New York hospitals between 27 and 28. So 15 years ago, but it wasn't published until 10 years ago. The primary outcome was inpatient mortality. The secondary outcomes were pulmonary and cardiovascular complications. Again, general anesthesia used in over 2/3 of the cases, regional anesthesia used in almost 1/3 of the cases. The inpatient mortality was 2.4%. With regional anesthesia, his review found lower odds of inpatient mortality and pulmonary complications. The trend toward improved outcome with regional anesthesia was seen with patients who had intertrochanteric fractures. There was no similar association between regional anesthesia and outcomes among patients with a femoral neck fracture. So he concluded mortality and functional impairment were greater after intertrochanteric fractures, but there was no difference in the odds of a major cardiovascular complication according to anesthesia type. This is again Mark Newman et al. In Anesthesiology 2012. Then in 2014, the same author with a similar group published a study in JAMA, Journal of the American Medical Association. This was a matched retrospective study of hip fracture patients, again in New York, longer timeline, 2004 to 2011. Where he tested the association of regional anesthesia versus general anesthesia, looking at 30-day mortality, and added another outcome such as the hospital length of stay. So 56,000 patients reviewed, general anesthesia, again, more than 2/3 of the patients, regional anesthesia, 1/3. His mortality finding was higher here, 5.3%. So he concluded the use of regional anesthesia compared with general anesthesia was not associated with lower 30-day mortality. Regional anesthesia was associated with a slightly shorter length of stay, 6.2 days versus 6.6 days. And is length of stay truly related to a reduction in complications? So Dr. Newman concluded regional anesthesia was not associated with a statistically significant difference in mortality. This is the cover of Anesthesiology in March 2018. Daniel McIsaac published a study titled Association of Hospital-Level Neuraxial Use for Hip Fracture with Outcomes, a population-based cohort study. This study looked at patients at the University of Ottawa and the University of Toronto. This was a cohort study of all Canadian hip fracture patients older than 65 years, retrospective analysis between 2002 and 2014, the proportion of patients at each hospital who received neuraxial anesthesia the year before surgery. 107,000 patients, almost half had neuraxial anesthesia, so greater percentage in Canada than in the United States. His primary outcome was 30-day survival. His secondary outcomes were the length of stay and the cost. So he found a wide variability in the use of neuraxial anesthesia between hospitals. The 30-day mortality was much higher, 8.5%. The survival improved if the hospital performed neuraxial anesthesia for more than 20 to 25% of patients the previous year. So, secondary outcomes. The length of stay was much longer, 9 days, than when compared to patients in the US. He found no difference in length of stay when comparing patients who had general anesthesia or neuraxial anesthesia. So, the conclusions, as I interpret them in Canada, if you go to a hospital which uses neuraxial anesthesia for more than 25% of hip fracture patients, your survival is increased. Why? Perhaps higher rates of neuraxial anesthesia may be a proxy for underlying quality of care. The most recent studies, November 25, 2022, New England Journal of Medicine, spinal anesthesia or general anesthesia for hip fracture in older patients. This is the REGAIN trial, regional versus general anesthesia for promoting independence after hip fracture. Again, Mark Newman with a score of other authors. This was a multi-centered, pragmatic, randomized superiority trial in 46 US and Canadian hospitals. Important to remember, 22,000 patients were screened. They were previously ambulatory. And the second point to remember, these patients were 50 years of age or older, a much younger definition of, quote, the older patient. The patients were randomly assigned in a 1-to-1 ratio to receive spinal or general anesthesia. Of 22,000 patients screened, only 1,600 patients were enrolled. Spinal anesthesia given to 795 patients, general anesthesia 805 patients, and the mean age of these patients was 78 years. The composite primary outcome was death within 60 days, not 30 days, and in spinal anesthesia, 3.9% patients died, and in general anesthesia, 4.1 patients died, so no difference. The secondary primary outcome, inability to walk 10 feet independently. There's where the independence feature appears. In spinal anesthesia, 15% could not walk 10 feet and 14.4% could not walk 10 feet. So no difference. The REGAIN trial had secondary outcomes as well. They included the two components I just mentioned, death within 60 days and inability to walk 10 feet independently. They also included new onset delirium, time to discharge, and ambulation at 60 days. Let's talk about new onset delirium. In the patients who received spinal anesthesia, 20% had new onset delirium. General anesthesia, 19.7% had new onset delirium. The time to discharge was equivalent at 3 days. I want you to understand, in spinal anesthesia patients, sedation was allowed and was at the discretion of the individual consultant anesthesiologist. So in this REGAIN trial, the conclusion for hip fracture surgery, spinal anesthesia was not superior to general anesthesia with respect to the risk of death or new inability to walk independently at 6 days. The onset of new delirium and the hospital length of stays were similar within the two types of anesthesia. We have the newest study called the RAGA randomized trial study, published in JAMA, January 2022, the effects of regional versus general anesthesia on the incidence of postoperative delirium in older patients undergoing hip fracture surgery. A very small study, 950 patients, mean age at least 76 years with a minimum age of 25 years. This study was conducted in urban China. The RAGA trial, the primary outcome, delirium within the first 7 days postoperatively, regional anesthesia, 6.2%, and general anesthesia 5.1%. In this study, it's important to remember regional anesthesia was conducted without any sedation, so that factor was removed. So in the RAGA trial, regional anesthesia without sedation compared with general anesthesia did not significantly reduce the incidence and severity of postoperative delirium in older adults undergoing fragility hip fracture repair. All of these references will be included in the syllabus. So a word about transthoracic echocardiography. We may ask for this on occasion. What I ask is, can you tell me about the left heart function and size? Can you tell me about the valvular structure and function in this order? The aortic valve, mitral valve, tricuspid valve, and pulmonic. Most importantly, tell me about the right heart function and size, the pulmonary vasculature, specifically, is there pulmonary hypertension, and is there a patent foramen ovale? Why do I need to know these factors? Well, bone cement implantation syndrome, we call it the cementing syndrome. It can occur in one of 5 surgical stages: when the femur is reamed, when the acetabular component is implanted with cement, when the femur receives the cement under pressure, when the prosthesis is placed into the cement inside the femur, and finally when the hip itself is reduced. 5 surgical stages. What is the bone cement implantation syndrome? It's a clinical definition. We present often with hypoxia, hypotension, decrease in end-tidal CO2 acutely, profound cardiac dysrhythmias such as an SVT, ventricular tachycardia, asystole, and again, obviously, cardiovascular collapse. The bone cement implantation syndrome seen more commonly when a long stem prosthesis is inserted. Why? We use long stem prosthesis for a revision total hip arthroplasty or a patient who has a pathologic fracture. Why is it more common? Sometimes the cement burden is greater. Sometimes the prosthesis is under more pressure. So sudden death during primary hip arthroplasty. If the THA or arthroplasty is done to repair a fracture, the type of fracture influences the outcome. The intraoperative mortality is highest with patients undergoing repair of a pathological fracture, oftentimes patients who have metastases from breast cancer or renal cancer. Killer cement. This was from the Daily Mail in the United Kingdom. They call it killer cement. Patient risk factors, as I mentioned, old age, pre-existing physical reserve, which is poor. You already have an impaired cardiopulmonary function. You have pre-existing pulmonary hypertension. You have osteoporosis or bony metastases in the joint, and you may have an intertrochanteric fracture. So how does this occur? Well, there's 2 models, a monomer-mediated model or an embolic model. The physiological consequences are manifest via these dual pathways. The mechanical effects of inserting a prosthesis, there's reflex vasoconstriction, and the mediators are released, which cause an increase in pulmonary vascular tone. The primary pathophysiological derangement is an increase in pulmonary vascular resistance. So hence, patients with pre-existing right heart dysfunction or pulmonary hypertension are especially vulnerable. So the diagnosis, you have to be alert for hypoxia, decrease in end-tidal CO2. You may have concurrent transesophageal echocardiography available, and you may have concurrent pulmonary artery pressure available. How do we treat the implantation syndrome? Well, supportive care, quote unquote, increase the FiO2. Almost always on 100% FiO2 when I know cement is upcoming. Increase or maintain the intravascular volume, support the right ventricle with appropriate pressors or vasoconstrictors, inotropes, and using selective pulmonary vasodilators such as inhaled nitric oxide prior to and during cementing, or epoprostenol, Flolan, the trade name, and Velitri, which is also a trade name for epoprostenol, which does not have to be stored in a refrigerated fashion. So consider an uncemented prosthesis in patients with right heart dysfunction and pre-existing pulmonary hypertension. A surgeon will say to me, I have a patient coming up in the next 24 hours. Can you review his or her chart? Do you think he or she can tolerate cementing? Consider an uncemented prosthesis in patients with a very dire prognosis, and whether this is simply palliative surgery to relieve pain and allow transfer to home or hospice care. Patients cannot go to hospice care or physical therapy if they cannot be turned, and if they are in such pain, they cannot be transferred. So I'm going to share with you a case report which occurred a few years ago. 92-year-old woman, daunting past medical history. She had had a coronary artery bypass for 4 vessels as well as a PCI. She was in atrial fibrillation with severe MR, severe tricuspid regurgitation, pulmonary hypertension, pressures in the 70 millimeters of mercury. She had chronic obstructive pulmonary disease, was on, quote, home oxygen when this fall occurred, current pneumonia, current carotid artery stenosis, deemed not a surgical candidate, in chronic renal failure, and had a mechanical fall with a left femoral neck fracture. Here's an image of the x-ray. Taken to a hospital in the community where her family was told the fracture would heal. The patient was transferred to our hospital and a surgeon. I can share this case report with you because she was the grandmother of our current chief resident. He came to me in the OR 22, the trauma OR, and said, my grandmother was just transferred here. Could you please review her chart? I opened up the chart. Her ECG showed ST segment changes in the anterolateral leads. I said, you need to find a surgeon. Oh, I already have found a surgeon. You need to do the following 12 steps, and then we can review this at the end of the day. Please check her troponins, check a transthoracic echocardiography, check her INR. She was receiving warfarin concurrently. You need to treat that pneumonia, treat her bacteriuria, give vitamin K, of course, stop the warfarin. Treat her tachycardia with metoprolol. Her heart rate was 120. Treat her bronchospasm with beta agonists. Most importantly, you need to find an open operating room and a post-operative ICU bed for your grandmother. He came back to me later that day and said, I've done all those steps. Okay, the ball is now back in my court. I discussed the surgical plan with the trauma surgeon, whom I know quite well. She had a femoral neck fracture. We discussed the position. She was going to be in the lateral position for an uncemented hip hemiarthroplasty. I made a plan for venous and arterial access, and I can plan to do a continuous spinal catheter anesthetic. But most importantly, we discussed the goals in a broader sense. We all agreed that resuscitation would not include cardiopulmonary bypass or extracorporeal mechanical oxygenation or ECMO. I found the only spinal catheter kit in our workroom which had not expired. I placed a continuous spinal catheter via a lateral approach. I gave her 0.5% bupivacaine, 1 milliliter, and confirmed that this catheter was working. When I check whether a spinal is working, I don't use a pinprick test. I simply gently roll the hip. Once patients are pain-free, there's no agitation or anxiety. It's very easy to know that your spinal is working. I then allowed the surgeon to repair her femoral neck fracture. Here is an image of her on her side, right side down, awake, having her hip fracture repaired. So with that, I'll conclude by saying that hip fractures, there's a range of care. reasonably simple repairs such as DHS or TFN. There can be profoundly complex repairs such as a revision total hip arthroplasty. Our challenges continue. We have opportunities to improve outcome, but remember, it's one of medicine's great achievements. So thank you for your attention.